Hello. How childhood headache different from headache in adults? Headache in children and adolescents under-recognized and underdiagnosed because of misconception, myths, evolving migraine-like phenotypes of primary headache, children's limited verbal abilities to describe symptoms, migraine episode syndrome without headache. Especially in migraine, headache is absent or not a major symptom commonly. It's commonly presented as abdominal pain and discomfort, dizziness, vertigo, torticollis, motion sickness, behavioral disturbance, and sometimes sleep disturbance. On the other hand, headache is not a rare condition in the children and adolescents. It's highly prevalent, especially peak prevalence after adolescence, and in migraine, for example, range from 6 to 46, and tension time headaches similar as the most common primary headache disorders in this age group. And headache attacks disturb the quality of life physically, mentally, and academically, especially in children. We make the diagnosis in this age group according to the criteria of ICD-3 as well. In migraine, especially, we have to remind the possibility of episodic symptoms that may be associated with migraine in this age group, like cyclic vomiting syndrome, abdominal migraine, benign paroxysmal vertigo, and benign paroxysmal torticollis as well. On the other hand, other headache subtypes is not rare in this age group. Making the diagnosis, we have to keep in mind the importance of the observation. What I mean that, for example, a child, during attack a child, avoid watching TV means photophobia, phonophobia, and severe headache attack. Stop playing means that physical activity aggravates headache attack. Refuses to eat means loss of appetite and or nausea. Frequent sniffle means that possible associated between migraine and atopic disorders. Headache presentation is an important issue. What changed from the childhood to adulthood? First of all, location is changed. In children age group, location is commonly bilateral, but after puberty, it's turned to unilateral, commonly located on periorbital or suboccipital region. Quality is commonly pressing and non-throbbing in children age group. After puberty, it turns step by step throbbing headache attacks together with allodynia and subtle neuropathic changes. Duration of headache attack commonly shorter than 2 hours, sometimes minutes to 30, 1 or 2 minutes to 30 minutes, for example. And after puberty, headache duration is longer than 4 hours, depending on the intervention and the comorbidities. Headache intensity generally low to moderate in childhood age group. After puberty, it's turned to moderate to severe headache attacks. And also associated symptom is slight and commonly presented with abdominal discomfort, vertiginous symptoms, travel sickness, intolerance to physical activity. But after puberty, associated symptoms will be severe as described in ICD-3. Headache attack triggers commonly physical factors in the children and adolescents, like sleep problems, screen dependency, irregular meal, dehydration, foods, exercise, and sometimes stress. But after puberty, physical and psychological factors more commonly reported as a triggers. For example, sleep problems, stress, screen dependency, especially in the pandemic days, irregular meal, dehydration, hormone replacement therapies, menstrual cycle, and seasonal changes. Aura is not a frequent symptom as adulthood in children and adolescents. On the other hand, if a child describes aura, commonly visual, brainstem, or motor aura, Aura symptom is slight than adult. After puberty, visual and sensory aura will most prominent than the childhood. You can see here a comparison of migraine in children, tension type headache in children, and migraine in adults. You can see changing quality of sight, laterality, pain, time, nature of pain, associated symptom, aura, and disability. Gender is an important issue in childhood and adolescence headache attacks, especially after puberty. We can see in migraine headache attacks, attack frequency, and the other symptoms change in favor of the girls. In the adulthood, age-dependent change also changing the subtypes of the migraine. For example, you can see here a study of ours changing characteristics, age-dependent changing characteristics of the migraine with aura and migraine without aura in the aspect of duration, frequency, nausea, photophobia, and phonophobia in the woman. On the other hand, migraine without aura group, nearly whole of the headache qualities changed in the room in favor of the woman. For this reason, we can say that headache duration and the duration of illness is an important issue in female, and another issue is the predictors of the chronification of the migraine attacks. In all of the age group, we can say that migraine is not just a headache. Associated comorbidities seen in all age groups, but in children and adolescents, we can say the importance of the associated comorbidities like ADHD, tic disorders, autism spectrum disorders, epilepsy, vertiginous disorders, patent foramen ovale, atrial septal defect, atopic disorders. Asthma is more common than adults. With increasing age, we can see the increasing frequency of the comorbid sleep disorders, psychiatric problems, gastrointestinal problems, and the vascular problems compared to childhood. Chemo studies showed us the importance of the common comorbidities in the aspect of the chronification, and we can say that comorbid disorders like respiratory pain disorders, psychiatric disorders, and cardiovascular disorders increase the frequency of the chronic migraine in all age groups, especially in adults. In natural course of migraine in children age group, we can say that the remission and relapses they are. Anxiety, school exam, and other stressful events make triggered bad spell in some children are evident in other children. 40 to 60 of school children with migraine will grow into adults with migraine. In some children with migraine, diagnosis can change tension type headache and vice versa, especially during puberty. Trajectories of headache attacks, we can say the importance of the intensity of pain and frequency of pain. And results of the multinomial regression analysis, we can say that girls with moderate headache attacks affected by the parental headache history and associated depression and anxiety. On the other hand, boys with moderate headache attacks affected with associated parental headache attacks and also dysfunctional stress coping. Finally, we make a diagnosis episodic headache attacks like tension type headache, migraine, or other rare headache disorders with short headache attacks. And on the other hand, acute onset headache attacks, we make a diagnosis commonly primary headache disorders, like migraine, but always have to exclude the secondary reasons of the headache attacks. And chronic progressive headache attack commonly is secondary causes, and we have to make the diagnosis perfectly. Always we have to keep in mind the red flags, like a short headache history attack, first or worst headache attack, accelerated course of headache attacks, symptoms of raised intracranial pressure, personality change, underlying diseases, and young age of children, especially younger than 3 years. And depending of the this patient's presentation, we have to decide the indications of neuroimaging in children with headaches. And you can see here a summary list of these situations, like features of cerebellar dysfunction, ataxia, features of intracranial increased intracranial pressure, features of focal neurological deficit, personality change, deterioration of schoolwork, change in headache character, or a new neurological deficit. In these cases, we have to ask a neuroimaging in children with headache. Finally, I can say that childhood and adolescent headache is often under-recognized, under-diagnosed, and under-treated all over the world. Good communication with patients, relatives, and school teachers is essential for diagnosis, also management. Changing headache phenotype with age and comorbidities have to take account. Psychological, environmental, and biological interactions are remarkable. Consider the subjectivity of each individual. Analyze every aspect of child life in order to fully understand disease. More readings, you can see these tables. Thanks for your attention.